Good afternoon and welcome to this Spring Day, 1st of September edition of the Midweek COVID update. Let me go straight on to where we are. So let's look at our curves. Right, we've got a kind of a strange kind of appearance of, it's not this kind of symmetrical curve that we had for the first wave and the second wave. Coming down, we've got this kind of prolongation, and looks like the third wave is going to be quite a lot longer in duration, not the normal 75, 76 days, but maybe longer than that. I think this is a reflection of the fact that the epidemic is still carrying on in a number of provinces. I'll come to that just now. But certainly in Gauteng, we've come right the way down from being very high. We're almost down to baseline. One of the questioners has asked me, what do you mean by baseline? What I mean by baseline is that the reproductive number, that R0, that governs the infectivity of the virus in that particular environment, is less than 1. So in other words, it is not propagating, but it's still lurking in the background. When I say propagating, certainly there is some cases, but it's not expanding as it would do in a normal epidemic. That's what I mean by baseline. And in Gauteng, it's coming pretty close to the baseline over there. The other provinces in the Western Cape also coming down, but still pretty high at the moment, but looking optimistically like it is coming down now. And similarly with the Eastern Cape starting to come down, the curve has got its inflection, means that it's starting to come down now, and also in KZN. But in all these those three provinces, it still is a reasonably high level. What I really want to point out in this picture over here is if we look at the hospital admissions, one of the questioners has asked me about hospital admissions. In the first wave, there is this gap between the new cases and the hospital admissions, but I think this is probably partly artifactual in that the notification system may not have been as good as it is now. But if you look at the second wave, and the hospital admissions follow pretty closely up to the apex, there's a gap over here, follow pretty closely to the new cases, the 7-day moving average of new cases. But what I wanted to point out in the third wave is that there is quite a discrepancy between hospital admissions, and the notification system now is pretty good, and the daily cases. In other words, there seems to be now a discord between the number of cases is significantly higher than the number of hospital admissions. And again, looking at this, it may well be indicating that the vaccination is now starting, the vaccine rollout is now maybe starting to have some effect on reducing hospital admissions. We've seen that, and of course, I'll come to that just now, in many countries in the Northern Hemisphere with advanced vaccine coverage, that the main effect has been to reduce hospital admissions, severe disease, and of course, mortality. And maybe we're starting to see that now in South Africa, perhaps in a small way. So where are we with our vaccination status? Sorry, this is actually wrong. This is actually the 31st of August. I forgot to amend that. Fully vaccinated, 15% of the adult population. Partially vaccinated. Fully vaccinated means that 1 dose of Johnson & Johnson, 2 doses of Pfizer. Partially vaccinated, 1 dose of Pfizer, 16.5%. The total number of individuals vaccinated, just under 10 million, and approaching a quarter of the adult population. In other words, individuals who received either partially or fully vaccinated. So there's a little bit disappointing. We really hope that we would get quite a bit further than this. And in fact, if we look at the daily doses administered on the 31st of August, 261,000, we really were hoping to get up to the 300,000 level. And even though we've lowered the age of entry into vaccination, still hasn't pushed us up to 300,000. So a little bit disappointing in terms of vaccine rollout. I think what we're really worried about are now vaccine apathy. People just couldn't be bothered to go and get vaccinated, and vaccine hesitancy. People are nervous to go and get vaccinated. And I think we need to kind of address that. We need to improve access to taking the vaccine, to taking vaccination to people in workplaces and industry and so on, with regard to the vaccine apathy, and with regard to vaccine hesitancy, to improve our communication, to reassure people that the vaccines are safe, because I think there's a lot of vaccine hesitancy out there. Also, one of the problems, and we've kind of highlighted and emphasized a number of times, is the lack of weekend vaccination. This is on Sunday, 29th, only 22,000 doses of vaccine administered in 24 hours. Again, a bit disappointing. Now, I showed this last week, and I had quite a few comebacks on this. People are starting to get a little bit despondent. You know, this is what happened in Israel, where 67+% of individuals were vaccinated. And as I pointed out last week, despite this high level of vaccination, there still are an upsurge of cases. There still have been an upsurge of cases. We see this in daily new confirmed cases. Most of these, in fact, have been individuals that have been vaccinated, but fortunately, the great majority of these mild cases. But nevertheless, quite a significant upsurge of cases. Admissions to hospital also increasing, and mortality increasing as well, most of these being unvaccinated individuals. But as I pointed out last week, what is disappointing is that even if you've got a high level of vaccination, it's still not stopping significantly the circulation of the virus, which is now picking out the unvaccinated individuals. So a lot of people have been saying, well, you know, what is the point of vaccination? You know, we're still getting all these cases. And I did point out that the main reason is that it's limiting the severe cases. But there is a bit of kind of despondency creeping up. People are looking at, for example, the Delta virus that seems to be escaping the vaccine, certainly in terms of symptomatic illness. Protection less than 50%. These are United States data. Prevention of infection, somewhat less than 40% even. But good protection against hospitalization and severe disease. And now more recently, data coming out from a number of research studies. This is from the NICD in South Africa, the C12 lineage. Some people are calling it a variant, it's actually a lineage. In other words, it's a mutation which is being passed on to progeny virus, but hasn't yet established itself in the general population. At the moment, it's about 2% of the viruses in South Africa which have been isolated. But it is worrying because this particular lineage has got a large number of mutations, and many of them in the critical sites. For example, the sites which give the Delta variant, it's negative characteristic, it's worrying characteristics. And the Delta variant itself, this is a study done in Japan where they were artificially able to put these mutants into the Delta variant and show that it is actually able to completely resist the vaccines made against the wild type virus. In other words, are the vaccines that we're using, which use the initial prototype of virus to make vaccines. So we're getting all these negative kind of feedback coming in, and people are starting to get a bit worried. So I thought what I'd do now, because we're on Erev Rosh Hashanah, coming up to Rosh Hashanah, and give you something to kind of pray, because I'm going to look at the more optimistic side of things. And I want to kind of point out to you that where are we in terms of combating this disease? Now, looking at any epidemic or pandemic of a controllable, usually vaccine controllable disease, it goes through 4 phases. Our first phase is what we call containment. After we've contained the pandemic or epidemic, we go on to control, the control phase, and then elimination, and then eradication. And I'll show you how this applies to COVID. So we are now in the containment phase of the COVID pandemic. We are using first-generation vaccines. We're now 2021 going to 2022. And it has shown in countries where there is high vaccine coverage, and hopefully we're also getting there in this country, a marked reduction of serious illness. With regard to mild to moderate illness, only somewhat reduced. We can't really expect that the vaccine in this stage of containment is going to severely or seriously reduce mild to moderate illness or infection. Is only somewhat reduced. And therefore, all our preventive measures, all our restrictions, our non-pharmaceutical interventions are still obligatory because we still need to rely on preventing individuals transmitting from each other, from person to person. So this is where we are in our containment phase now. And just to reiterate, I've shown this on several occasions, the difference between what vaccination, even in the containment phase, even with our first generation, what that achieves. In the United Kingdom, in their second wave, where there was no vaccine coverage, you could see that as the cases increased in the second wave, together with that, the severe disease and deaths increased proportionally. But in the third wave, where there was vaccine coverage at a high level, you could see that the cases still increased in the third wave, but these were mild to moderate cases. Where it came to severe cases, that was markedly reduced. So that's what we achieve in our containment phase with our first generation of vaccines. And that's really what we need to expect. We still need to have all the preventive measures, all those restrictions to try and reduce mild cases, but certainly to kind of augment what the vaccine is achieving. Then our next phase is a control phase. And this will be for next year, and I'm being optimistic about this, but I think with reasonable grounds, I think there's good scientific evidence that second generation vaccines will be developed sometime, maybe even at the end of this year, and there are clinical trials already on candidate second generation vaccines going into 2023. In the control phase, the serious illness will be drastically reduced, and it's really only at-risk individuals who will either succumb or will have to require hospitalization in this phase. So this is going to be equivalent to what we now have with influenza. Influenza does affect the severely at-risk individuals, the frail elderly, people with severe underlying illnesses, and so on. Mild to moderate illness will be reduced to tolerable levels. We won't get rid of it completely, but we'll have it at a level that we can tolerate. It'll be similar to, for example, influenza, which affects us every winter. So as with the other endemic coronaviruses, the SARS-CoV-2, which causes our present COVID, will be at a tolerable level, causing minor or relatively minor illness maybe every winter season. And the infection will be present at endemic levels and give rise to these annual bouts of tolerable upper respiratory infection. And fortunately, then we can go back to our pre-COVID level, maybe keeping some of the restrictions. So, for example, sanitizers at shopping malls and that kind of thing. But maybe at that stage, there won't be the necessity for masks and restriction of crowding events and so on. The next phase of elimination and eradication, we will not get to with COVID. This is what we have got to, for example, with polio, which is only seen in some countries. Our young doctors don't see polio anymore, or measles. We don't see very little measles now. It's controllable by vaccination. But we cannot get to that with regard to COVID. That elimination phase and eradication is only being achieved with one infectious organism, and that's smallpox. That'll be unattainable with COVID for a number of biological reasons. Unfortunately, I won't have time to go into that now. So just to sum up, we are now in this containment phase, which is managed by first-generation vaccines. Very good vaccines, but not the ultimate in vaccines. Very good in reducing serious illness, somewhat not quite as good in reducing mild illness, not quite as good in reducing infection, and therefore we need to have restrictions. Our next phase with the second or third generation vaccines, much better vaccines. Maybe at a future time I can share with you the excitement in the research which is going into developing second and third generation vaccines. And then we'll have it at a tolerable level, very similar to what we got with influenza. With regard to drugs, I really do not think that we will get to a stage where there will be breakthrough drugs. There certainly has been great advances in management of COVID with high-level oxygen treatment, high-flow oxygen treatment, for example, or steroids. But these are managing the effects of the infection. To have drugs which will combat the infection directly, I don't think any scientist is really optimistic that this will happen anytime soon. So I'll leave it there, and maybe now go on to some of the questions which have come through. I'll try and get through a few now in the time that's left to me. A question I asked, would vaccines work on previously infected individuals? In other words, if you've had COVID before, should you go for vaccination? And of course, the answer is an unequivocal yes. This is what we call hybrid immunity. In other words, where the natural infection acts as a primer and the vaccine acts as a boost. And in that situation, actually, you get a very, very good immune response. So people that have had COVID should be vaccinated, and they will then get a very good, a very high level of neutralizing antibodies and very good immune protection. Related to that, there's a question who asked about, is natural immunity superior to the vaccine? Well, with most infections, yes. We look at something like measles, for example. We look at polio, look at all the other, well, not all, but most infections. The natural infection gives you a better immunity than the vaccines do, than the artificial immunity. In COVID, however, it's the other way around. Natural immunity is good, but not as good as the vaccines. The reason for that is that the vaccines have been tweaked, specially tweaked and specially modified to give a very powerful, a very strong immune response. So with COVID, in fact, the vaccines give a somewhat better immune response than the natural immunity. But this combination, this hybrid immunity, having your natural infection as your prime and your vaccine as your boost, there you get exceptionally good immunity. That combination seems to be very good, a very powerful immune stimulation. Then I've got two questions I'll deal with. People asking about symptoms after vaccination. So one person is actually a little bit worried because I didn't get symptoms, and neither did I, and many other people. And they're fortunate. It doesn't mean that you haven't got an immune response. It's really just a personal sensitivity to the various chemical mediators which start off the immune response. They got technical names, chemokines and the interferons and cytokines and so on. Some people are more sensitive when these are released into the body. Other people are less sensitive. It's got nothing to do with whether the immune response is working or not. Then I've got another question from a gentleman some time back who has some lingering symptoms, weakness in the arm and weakness in the hand. I haven't really heard of this as being a side effect of the vaccine. Really why I bring this up is that the kind of side effects are really the flu-like symptoms which you get a day or two afterwards, maybe pain and tenderness at the site of vaccination. Those are the usual things which can be treated with a paracetamol, a Panado, or an aspirin. But any other things, I think you really need to see your doctor. It's difficult for me to kind of give advice, not seeing you, not examining you, not knowing your clinical background. So I think things like that, like any neurological symptoms, that I think you need to alert your medical practitioner to look at it to make a diagnosis. Then I'm getting a lot of questions. I'm lumping these three questions. They're related questions about top-ups and about boosters. Now, the issue about boosters is internationally and nationally quite a controversial one, because we don't want to use boosters if they're not that necessary and waste boosters where we really kind of need to distribute it. And the kind of main thing is to get as many people vaccinated as soon as possible. So, for example, the question about healthcare workers, do they need a top-up? The data so far would say that they probably do not. And I'm saying probably because if we look at all the parameters of the immune response is still pretty robust well after 6 months. It is being looked at whether a booster might not be required after 6 months of people that had the Johnson & Johnson. I think we're still looking at that. It's been being looked at intensively throughout the world. In fact, there's actually an important World Health Organization seminar this coming Friday, specifically looking at this question. And we are also part of that. But at the moment, right now, on 1st of September, we are not advocating boosters for the people that had 1 dose of Johnson & Johnson or 2 doses of Pfizer. I've actually got a question from somebody that had the Johnson & Johnson vaccine, followed by a Pfizer booster, which I think was not probably necessary, and asking, do they need a second Pfizer? Well, clearly not. I mean, clearly not. If they've had already 1 booster after Johnson & Johnson, in other words, to have 3 vaccinations, although, of course, in a number of countries overseas, they are giving triple vaccines. I think it's really on empirical grounds. I don't think there's good scientific evidence to say that it is necessary. And then, another person has asked, can they take cortisone after vaccination? Yes, there's no reason not to. I'll end off with this last question. We've talked a lot about variants. Are variants always dangerous, or do they always give rise to bad viruses, evil viruses? No. The great majority of variants, in fact, harm the virus and are actually lethal to the virus, and the virus dies out. The mutations mostly are negative to the virus. It's only the relatively few, in fact, probably very, very few, which gives rise to selective advantage to the virus, so that the virus can replicate, either escape immunity or become more contagious. That's a tiny minority of the mutations which give rise to those variants. So I'm just going to end off and just make 1 or 2 announcements. Next week, of course, there won't be a midweek update. It's being Rosh Hashanah. So we'll meet again in 2 weeks' time on the 15th of September. And then after that, there'll be Sukkot, the Yom Tov. So again, there'll be 2 Wednesdays that we won't have it. And we resume again normally from the 6th of October. So there will be one next Wednesday on the 15th of September. And then after that on the 6th of October. So I just want to also just mention about Rosh Hashanah. I've had a lot of questions. People here getting visitors coming from overseas. I think the one question, or I need to make 2 points. The one point is that people who come from overseas, like from Israel, might have had 3 shots, 3 doses of the vaccine. Doesn't guarantee that they're not carrying the virus. It will be greatly reduce their chances of being infected, but doesn't guarantee that they're completely free of infection. So I think all the rules that we keep on hammering, I think we need to apply. Limit the number that you're going to have at your Rosh Hashanah dinner. Keep the physical distance as much as you can, particularly from people that are outside your family bubble, people coming, visitors either from inside the country or people's coming from overseas, and try and minimize the amount of socializing without a mask. I think these are rules we kind of have had a number of times. Shuls, please, if you can get into the habit of sanitizing your hand when you go to shul, sanitizing your hand when you come outside, and then washing with soap and water when you get back home again. Try and minimize the amount of socializing. I know it's very difficult over Rosh Hashanah. And wear a mask over nose and mouth. If the mask slips under your nose, it's actually useless. It has to cover your nose and your mouth. I know it becomes a bit more comfortable. If you do have to have a mask break, then please go outside. If you have to blow your nose, please go outside the shul, lower your mask, blow your nose, and then importantly, sanitize your hands again before you enter into shul. It's for your own sake, but also for other people as well. So I'm going to end off, and to all of you, please stay safe, stay well, and to all of you, Chatima Tova, Shana Tova. Thank you. Bye-bye.